Morning, everyone. Two studies that I wanted to discuss today with folks that have come out relatively recently. Hopefully folks can see my screen now. Actually, three studies, sorry. The first is not actually published yet in literature, but this is from a media release from Regeneron, and that is a new study that looked at the use of their combination monoclonal antibody product, that's casirivimab and imdevimab, for post-exposure prophylaxis of household contacts of diagnosed COVID-19. So this study looked at roughly 750 patients that they treated with post-exposure prophylaxis with the Regeneron product versus another equal number of placebo controls. And so this was identifying household contacts of known cases, giving those household contacts a subcutaneous injection of a single dose of the Regeneron combination product, and then following for the development of symptomatic infection. And what they found was a dramatic 93% reduction in risk of symptomatic COVID-19 in those treated patients with the development of disease 1 week or longer after exposure. The reduction was slightly less, 72% if the onset of disease was within 1 week, but obviously the argument there is many of these people were infected and already developing illness before they received the treatment. And but it looks as if you catch it early, you can have a greater than 90% reduction in symptomatic infections among those patients that are treated. It also appeared that there was a dramatic reduction in the amount of virus shedding in those patients. So this is pretty gratifying and continued support of the idea of early use of monoclonal antibody therapies. Whoops, sorry. This is obviously huge because it's the first study that really demonstrates household contact post-exposure prophylaxis, and also the effect of subcutaneous injection, which obviates the need for IV infusion, which has been a barrier, as many of you know, to being able to deliver these monoclonal antibody products. So good news here. Again, this is not yet FDA EUA approved for use yet in the subcutaneous injection for post-exposure prophylaxis, but one can imagine that this would be coming rather quickly down the line. Second study is a study that was done in Israel looking at real-world effectiveness of the Pfizer vaccine, which has been used to vaccinate the majority of the Israeli population now, against B117 and B1351, that's the South African variant, breakthrough infections. And so this was a study conducted between late January and early March, looking at a large healthcare organization that covers about 53% of the Israeli population. And at the time that this study was concluded, you can see that about 55% of the Israeli population had at least partial vaccination completed. And so that's roughly 2 million vaccinees that this followed and looked at test results data from those 2 million vaccinees. And what they found, and interestingly, you can see this is a period of time when B117, by the end of this study period, was essentially almost all of the virus in Israel. What they found is for people who were fully vaccinated, there did not appear to be a difference between B117 and wild type infection in terms of the risk of breakthrough. That seemed to be relatively equal between vaccinees and controls. Interestingly, they did find that for people who had partial vaccination, so had received one dose but were not greater than 1 week after their second dose, For some reason, those people did seem to have a higher risk of having B117 versus wild type infection. And that may just reflect that the vaccine does not necessarily protect quite as well against B117 as it does against the wild type. And that would correlate with some of the findings that we've seen from antibody binding studies. What is also very interesting is that the odds of being infected with the South African variant B1351 those odds were dramatically elevated in vaccinees 8 times, which indicates that B1351 is more capable of breaking through vaccine imparted immunity than wild type or B117. I think the good news there, however, though, is if you look at those curves on the bottom left, which show the proportion of different viruses over the course of the study, you can see that wild type, that B117 went from representing about 70% of the viruses to essentially 100% of the viruses over that month and a half of the study period, while B1351 stays relatively at the same level in the 2 to 3% range throughout the course of the study. The numbers are still low, so it's hard to get an exact bead, but what you don't see is a steady increase in the number of B351 infections. And that may indicate that in a population that is highly vaccinated and where disease is effectively contained, as has happened in Israel, throughout the course of February and March, that it becomes much harder for some of these variants to proliferate, such as B1351. That is our hope here in the US, that eventually as we get well above 50% vaccination rates, we'll start to be able to suppress transmission and limit the opportunity for some of these more concerning variants like P1 to proliferate. The last study I want to talk about came out about a week and a half ago, I think, in MMWR, and this looked at a prison outbreak that occurred in Wisconsin in late summer, early fall. And really highlights, I think, some of the characteristics of disease transmission in populations, particularly in congregate settings. So this was a medium security prison of about 1,200 prisoners. They were housed across 15 different units. Those units share bathrooms and common areas. One of those units is a 150-person dormitory style unit, so shared sleeping arrangements and common areas. During this period of time, throughout the whole study, the prison had already implemented significant mitigation measures, non-pharmaceutical interventions, including mandatory mask wearing at all times for staff members and prisoners. The instigation of this outbreak was 6 prisoners who were transferred from a central intake facility on August 13th and were tested between the 17th and 19th, tested positive. They were among a larger group. And were quarantined, during their intake processing with a larger group of prisoners that were then, dispersed throughout the prison. Interestingly, the quarantining process that the prison used did not reset the clock when one of the quarantined persons tested positive within a group. And so the quarantine period ended around the end of August, and then they did not reinitiate continue quarantine for multiple groups moving forward. What they found eventually is almost 80% of the prisoners throughout the course of this outbreak became infected. A larger proportion, you can see 14% out of the 15 units were in that one dormitory style unit, but that means that 86% of the infections were outside of that unit. So it was really spread throughout the entire prison. And ultimately 6 prisoners ended up being hospitalized and 1 died. It doesn't say exactly what proportion of these prisoners were symptomatic versus asymptomatic, but as you can see, almost all of the prisoner cases were diagnosed with mass PCR testing. And so it would appear that many or even most of these cases were actually asymptomatic. The other thing to note, and if you look at the staff, there's a similar epi curve there where a large proportion of the staff are also detected through this mass testing effort. And again, about 23% of the staff total tested positive. But looking back, I think it's dramatic to see how long of a timeline this outbreak had moving through the prison. So eventually 80% of the prisoners are infected. So, and not all of the prisoners were tested. So, you know, a huge outbreak. But as you can see, it took 2.5, almost 3 months for the outbreak to run its course, even in a congregate setting. And I think this reflects how universal interventions like masking and social distancing and hygiene measures actually change the dynamics of transmission within a community and slow the kinetics down incredibly. And so instead of these large, explosive, rapid outbreaks that we would see, you know, such as the Diamond Princess, for instance, where you had a large proportion of people infected within a 1 to 2 week period, in some of these settings where mitigation measures are in place in a congregate setting, it can drag that that epidemic out for months. And this is exactly the flatten the curve idea that we talked about last spring, that when you put these measures in place, they dramatically, you know, kind of compress the epidemic curve and reduce the peak, but they don't always ultimately reduce the total number of cases. Now, I think that it's been shown that implemented in the correct way and outside of a congregate setting, you can dramatically reduce the total number of cases, but congregate settings are congregate settings and they are high risk. And so I think this is a lesson that we need to take into account when we're also looking at transmission events in schools, because often epidemiological studies that have been done in schools and looking at school reopening have taken the period of 2 to 4 weeks as their period of time to measure the effect of school opening on the number of cases within a school. And you can see here, if you had measured within 2 to 4 weeks, you would have found a relatively low proportion of prisoners were infected. All of this is confirmed, by the way, by sequencing data, which shows that essentially every case in the prison was part of 2 related clusters. So probably 2 different viruses that are closely related in the prisoners that were brought in through the intake system. They may have ultimately been infected by a common source. But essentially, these are all related cases. So this is not multiple introductions coming into the prison. This is one single epidemic. And again, playing out over the course of almost 3 months. So shows that we really, I think, don't necessarily appreciate the time course of how this virus moves through populations, particularly within the setting of mitigation measures in a congregate setting. And I think, unfortunately, we've misinterpreted much of the data from schools and other congregate places because of this blind spot. That's all I got.